Hi everyone, my name is Melvin Ocaña and I'm going to talk about immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma, also known as renal cell cancer or renal cell adenocarcinoma, is the most common type of kidney cancer. About 9 out of 10 kidney cancers are renal cell carcinoma. Also, RCC usually grows as a single tumor within a kidney. Sometimes there are 2 or more tumors in one kidney or even tumors in both kidneys at the same time.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail 1 or 2 VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Applications in medicine. An important part of the immune system is its ability to keep itself from attacking normal cells in the body. To do this, it uses checkpoints, which are proteins on immune system that need to be turned on to start an immune response. Kidney cancer cells sometimes use these checkpoints to avoid being attacked by the immune system. But these drugs target the checkpoint proteins, helping to restore the immune response against the cancer cells.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you'd get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins Group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would yes, still have the same result.
Pros and cons. Pros. Currently, immunotherapy has seen tremendous development in the form of immune checkpoint inhibition and vaccines and decision please, which are being studied in this kind of tumor and are showing promise as important step in the management of this disease. Cons. It continues to be associated with poor prognosis.
I did discuss how immunotherapy came back into renal cell cancer. You know, we had cytokine, VEGF, and mTOR inhibitors for over 10, 12 years, and now immunotherapy is coming back in the form of checkpoint inhibitors, drugs that target PD-1, PD-L1, and CTLA-4. Initially, nivolumab was approved, in patients that progress after VEGF target therapy as a single agent based on an overall survival benefit, checkmate 025. And now we have a frontline combination therapy with nivolumab and ipilimumab, which is a CTLA-4 blocker that showed an overall survival benefit versus sunitinib standard for more than 10 years. And what I went through my talk is also looking at the different combination of immune checkpoint blockers with VEGF targeted therapy that are making headways. We had phase 1 result with TKI that showed impressive response rate and tolerability, especially with axitinib. And studies made it to the phase 3 trials that are positive. And we had several phase 3 trial positive the past few weeks. So I discussed that in details while I mentioned that the landscape of renal cell carcinoma is going to remain pretty complex. And most important, there will be very unanswered questions.
Issues of plate in Ecuador. In Ecuador, immunotherapy has been commercialized since last year and has professionals with experience in its use and successful cases. Immunotherapy has been investigated in more than 20 different types of tumors, where it has shown high efficacy and an adequate safety profile, which is why it has regulatory approvals for use in patients with other pathologies, such as, for example, cancer of bladder, kidney, breast, and also for melanoma.
So it really, as I was mentioning, has been transformative for the care of patients with advanced RCC, and it's not sort of a new therapy either. We think of immunotherapy in kidney cancer, and it's not that long ago that it was the cytokine era, things like interferon and high-dose IL-2, and then in the mid-2000s, the introduction of anti-angiogenics, or blood vessel blocking agents, really transformed the management of kidney cancer at that time, and patients were living longer. And what we've seen more recently is with the introduction of immune checkpoint blockade, not just by itself, but often in combination with other drugs, has really led to dramatic responses in a number of patients. I think what's most exciting is it's not only that more patients are responding and more patients are living longer, that's tremendously important, but that we're seeing, hopefully starting to see at least, a tail of the curve, meaning that some of these patients really do seem like they have long-term or durable responses. And so the hope is not just to get better and better treatments, but actually to try to get to a point where we're having a lot more long-term survivors with kidney cancer. And the ultimate goal is cure, and getting towards that goal for more and more people.
Conclusion. Despite the rapid development of therapeutic modalities for advantage of metastatic renal cell carcinoma over the past decade to include traditional immunotherapy, such as high-dose interleukin-2 and interferon beta, as well as a number of targeted anti-angiogenic therapies, continues to be associated with poor prognosis.